Cracking the code on cirrhosis, your NCLEX deep dive. Hey everyone, and a massive welcome. I'm Razmeen and I'm thrilled you're joining me today. Welcome to our NCLEX-RN review on liver cirrhosis. Today we'll cover everything you need to know about this critical topic. Understanding liver cirrhosis isn't just about passing your NCLEX, it's about providing the best possible care to your future patients. This condition is complex, affecting multiple body systems, and as nurses we play a pivotal role in managing patients, educating them, and recognizing critical changes in their condition. So, grab your notebooks, get comfortable, and let's really get into the nitty-gritty of this. In this video, we're going to break down liver cirrhosis piece by piece. We'll start with the absolute basics. What exactly cirrhosis is and how it develops. Then we'll explore the common culprits, those underlying causes that lead to this serious liver damage. We'll differentiate between the subtle early signs and the more alarming late-stage symptoms, which is crucial for timely intervention. We'll also cover the diagnostic tests you'll see ordered, what those results mean, and the major complications that can arise. And trust me, NCLEX loves to ask about these, but we won't stop there. We'll delve into the treatment goals and the specific nursing interventions you'll be responsible for. And because I know you love them, we'll wrap up with some super helpful NCLEX tips and mnemonics to make sure this information sticks. My goal here is not just to throw facts at you, but to help you understand the why behind them, so you can think critically and feel confident. Let's make learning about cirrhosis engaging and, dare I say, even a little bit fun. Are you ready? Let's dive in. Cirrhosis 101, understanding the scarred liver. So, let's start at the very beginning. What exactly cirrhosis? Think of your liver as this incredible hard-working organ performing hundreds of vital functions. Cirrhosis is essentially the end-stage result of chronic liver damage. It's not something that happens overnight, it develops gradually over months or even years due to persistent injury and inflammation. What happens is that this ongoing damage leads to a process called fibrosis. Imagine your liver cells trying to heal themselves repeatedly, but instead of healthy tissue regenerating perfectly, scar tissue forms. This scar tissue is tough and fibrous, and it starts to replace the normal, functional liver tissue. As more and more scar tissue builds up, the liver's architecture changes. It becomes nodular and hard, losing its smooth, healthy texture. This scarring has two major devastating consequences. First, it disrupts the normal blood flow through the liver. The portal vein, which brings nutrient-rich blood from your digestive organs to the liver, faces increased resistance. This leads to a dangerous condition called portal hypertension, which we'll talk more about later. Second, the replacement of healthy liver cells with scar tissue means the liver loses its ability to perform its crucial metabolic functions, like producing proteins, detoxifying harmful substances, and aiding in digestion. It's like a factory slowly being replaced by concrete, unable to do its job. The culprits behind cirrhosis. Unpacking the causes. Now that we understand what cirrhosis is, let's talk about what causes this extensive damage. There are quite a few culprits, and for your NCLEX, it's important to be familiar with the most common ones. A helpful way to think about the broad categories of causes is to remember the concept of H.E.A.L, factors that harm the liver, leading to an exhaustive state, affecting its ability to function and ultimately leading to lasting damage. More specifically, the common culprits you absolutely need to know for your NCLEX include chronic viral hepatitis, particularly hepatitis B and C. These viruses cause long-term inflammation that slowly scars the liver over time. Another major player, and one we see quite often, is chronic alcohol abuse, or ETOH. Excessive alcohol intake is directly toxic to liver cells, leading to alcoholic liver disease, which can progress to cirrhosis. Then there's non-alcoholic fatty liver disease, or NAFLD, which is increasingly common and often associated with obesity, diabetes, and metabolic syndrome. Autoimmune hepatitis, where the body's own immune system mistakenly attacks liver cells, can also lead to cirrhosis. Other causes include biliary diseases like primary biliary cholangitis, which affect the bile ducts, certain genetic conditions such as Wilson's disease, causing copper accumulation and hemochromatosis, leading to iron overload, and finally, exposure to certain liver toxins, including some medications if used improperly or for prolonged periods. Spotting the signs, early clues versus late-stage warnings of cirrhosis. Recognizing the signs and symptoms of cirrhosis is crucial for early detection and management, and the NCLEX will definitely test you on this. It's important to distinguish between early and late manifestations because the early signs can be quite vague and easily dismissed. In the early stages, a patient might complain of persistent fatigue, a general lack of energy that doesn't improve with rest. They might experience anorexia, or loss of appetite, sometimes accompanied by nausea. Some individuals report a dull discomfort or tenderness in the right upper quadrant, RUQ, of their abdomen, where the liver is located. Unexplained weight loss can also occur. The liver itself might be enlarged, a condition known as hepatomegaly, which a healthcare provider might detect during a physical exam. As the liver damage progresses and its function significantly declines, the late signs and symptoms become much more pronounced and specific. Jaundice, a yellowing of the skin and sclera of the eyes, occurs due to the liver's inability to process bilirubin. Ascites, which is the accumulation of fluid in the abdominal cavity causing significant swelling, is a hallmark of advanced cirrhosis due to portal hypertension and low albumin. Peripheral edema, especially in the legs and feet, is also common for similar reasons. You might see spider angiomas, small spider-like blood vessels on the skin, and an increased tendency to bleed or bruise easily because the liver isn't producing enough clotting factors. Males may develop gynecomastia, enlargement of breast tissue. One of the most serious late signs is hepatic encephalopathy, leading to mental confusion, personality changes, and even coma, due to the buildup of toxins like ammonia. Asterixis, or a flapping tremor of the hands, is a classic sign of this. Urine may become dark, and stools can be pale or clay-colored. So how do we confirm a diagnosis of cirrhosis? It usually involves a combination of a thorough patient history, physical examination, blood tests, imaging studies, and sometimes a liver biopsy. Let's break down the key diagnostic tests. Blood tests are fundamental. We look at liver enzymes, specifically AST or aspartate aminotransferase, and ALT alanine aminotransferase. Interestingly, in early liver injury, these enzymes are typically elevated as liver cells are damaged and release them into the bloodstream. However, in late-stage cirrhosis, as the liver cells die off and there's less functional tissue, AST and ALT levels might actually decrease or normalize, which can be a bit misleading if not interpreted in context. Bilirubin levels will often be elevated, correlating with jaundice. We also check serum albumin levels. Since the liver produces albumin, levels will be low in cirrhosis, contributing to fluid shifts that cause ascites and edema. Prothrombin time, or PT, and international normalized ratio, INR, will be prolonged, indicating impaired synthesis of clotting factors and an increased risk of bleeding. Ammonia levels are crucial to monitor, especially if hepatic encephalopathy is suspected, as they will typically be elevated. Imaging studies like an ultrasound, Connecticut scan, or MRI can help visualize the liver's size, shape, texture, and detect nodules or signs of portal hypertension, like an enlarged spleen or ascites. But the gold standard for confirming cirrhosis and assessing the extent of damage is often a liver biopsy, where a small sample of liver tissue is removed and examined under a microscope. Alright team, this chapter is incredibly important, so listen up. We're talking about the major complications of cirrhosis, and these are absolutely NCLEX high yield. Understanding these complications, their underlying pathophysiology, and how to recognize them is critical. First on the list is portal hypertension. As we mentioned, the scarring in cirrhosis obstructs blood flow through the liver, causing pressure to build up in the portal venous system. This increased pressure forces blood to find alternative routes, leading to the development of varices, enlarged fragile veins, most dangerously in the esophagus and stomach. These esophageal varices are prone to rupture and can cause life-threatening bleeding. Another major complication directly linked to portal hypertension and low albumin is ascites, the accumulation of serous fluid in the peritoneal cavity. This can cause significant abdominal distension, discomfort, respiratory distress, and increase the risk of spontaneous bacterial peritonitis, or SBP. Then there's hepatic encephalopathy, or H.E.A.L, a neuropsychiatric syndrome caused by the liver's inability to detoxify ammonia and other toxins from the blood. These toxins reach the brain, leading to a spectrum of symptoms from mild confusion and personality changes to lethargy, asterixis, and eventually coma. Hepatorenal syndrome is a severe complication where patients with advanced cirrhosis develop renal failure, even without pre-existing kidney disease. Finally, coagulopathy, or impaired blood clotting, results from the liver's reduced ability to synthesize clotting factors, significantly increasing the risk of bleeding from any site. Chapter 6. Managing cirrhosis, treatment strategies and goals. When it comes to treating cirrhosis, it's important to understand that, in most cases, we can't reverse the existing liver damage. So the primary treatment goals are to slow down or halt the progression of the disease, actively manage the symptoms to improve quality of life, and most importantly, prevent and treat those serious complications we just discussed. For ascites, management often involves restricting dietary sodium intake to help reduce fluid retention. Diuretics are key medications here, with spironolactone, an aldosterone antagonist, being a cornerstone, often used in combination with furosemide. For large-volume ascites causing significant discomfort or respiratory compromise, a therapeutic paracentesis may be performed to remove excess fluid. For hepatic encephalopathy, the main goal is to reduce ammonia levels in the blood. Lactulose is a go-to medication. It works by drawing ammonia from the blood into the colon, where it's then expelled in the stool. Dietary protein intake may need to be carefully managed, sometimes restricted, especially during acute episodes, though adequate nutrition is vital. For esophageal varices, beta blockers like propranolol or nadolol are used prophylactically to reduce portal pressure and decrease the risk of bleeding. If bleeding occurs, treatments include endoscopic variceal ligation, banding or sclerotherapy, and medications like octreotide can help control acute bleeding. To address the bleeding risk from coagulopathy, vitamin K might be administered, and in cases of active bleeding or before invasive procedures, fresh frozen plasma may be given to replace clotting factors. Prophylactic antibiotics are often used to prevent spontaneous bacterial peritonitis in patients with ascites. Ultimately, for patients with end-stage liver disease, a liver transplant is the only definitive cure and may be considered as a last resort. Chapter 7. Nursing care and cirrhosis, your essential interventions. As nurses, our role in caring for patients with cirrhosis is multifaceted and absolutely vital. We are at the forefront of monitoring, managing symptoms, providing education, and offering support. Close monitoring is paramount. This includes regularly assessing vital signs, being vigilant for any signs of bleeding, such as melena, hematemesis, or oozing from IV sites. Daily weights are crucial for tracking fluid status, as is measuring abdominal girth to assess for changes in ascites. Strict intake and output monitoring helps us evaluate fluid balance and the effectiveness of diuretics. We also need to monitor mental status closely, using tools like the West Haven criteria, or just keen observation for subtle changes that might indicate worsening hepatic encephalopathy. Nutritional support is a big part of care. Patients often need a diet low in sodium to help manage ascites and edema. For those with hepatic encephalopathy, protein intake might be adjusted based on their tolerance and clinical status, aiming for adequate calories to prevent muscle wasting. Administering medications accurately and on time is key. This includes lactulose, diuretics, beta blockers, and any prescribed antibiotics or vitamin supplements. Patient comfort is also important. For instance, elevating the head of the bed can help alleviate dyspnea caused by ascites pressing on the diaphragm. Implementing bleeding precautions is standard practice, using a soft toothbrush, an electric razor, avoiding unnecessary injections, and applying pressure to puncture sites. Patient and family education about the disease, diet, medications, and when to seek medical attention is an ongoing responsibility. Chapter 8. ACE, your NCLEX, cirrhosis tips, mnemonics, and quick recalls. Okay, let's get to the part you've been waiting for. The NCLEX tips and mnemonics to help all this crucial information stick. For cirrhosis nursing priorities, remember the mnemonic cirrhosis itself. C stands for clotted blood, or rather the lack thereof, so monitor for bleeding due to decreased clotting factors. I is for increased bilirubin, leading to jaundice and itching, so think skin care. R means retention of fluids, ascites and edema, so think daily weights, abdominal girth and diuretics. The second R is for reduced mental status due to increased ammonia. Assess neurostatus frequently. H stands for hepatic encephalopathy. Remember lactulose is key. O signifies overuse of drugs or toxins, a reminder that these patients have impaired drug metabolism, so we must avoid hepatotoxic medications like acetaminophen. S is for sodium restriction and strict Y and O's. The second I is for I and O's and daily weight, reinforcing fluid balance. And the final S is for support the liver, and consider transplant if needed. There are certain signs and symptoms that require immediate reporting to the healthcare provider. These are red flags. Hematemesis, vomiting bright red blood, coffee ground emesis indicating older digested blood and bloody or tarry stools, melena, all signal active GI bleeding. Any acute change in mental status like confusion, slurred speech, or increased lethargy could mean worsening encephalopathy, and critically low urine output can be a sign of hepatorenal syndrome. For a quick NCLEX snapshot, table, remember, for encephalopathy, think increased ammonia, give lactulose. For ascites, measure girth, give spironolactone. For varices, it's a bleed risk, so think octreotide and banding. Nutrition is low sodium and protein is adjusted. Labs to monitor closely are INR, bilirubin, and albumin. And for medication safety, always avoid hepatotoxic meds like Tylenol. Finally, a quick recall phrase to keep in your mind. Liver is scarred, can't filter or clot monitor brain, belly, and bleeds. Outro, wrapping up key takeaways and your next steps. And that brings us to the end of our comprehensive review of liver cirrhosis. We've covered a tremendous amount of information, from the basic pathophysiology and causes, through signs and symptoms, diagnostics, those critical complications, treatment strategies, and essential nursing interventions, all topped off with some NCLEX-focused tips. My hope is that breaking it down this way has made this complex topic more manageable and understandable for you. Remember, knowledge is power, especially in nursing, where quick, informed decisions can make all the difference. Liver cirrhosis is a challenging condition for patients and healthcare providers alike, but with a solid understanding, you'll be well equipped to provide excellent care and to tackle those NCLEX questions with confidence. Don't let your learning stop here. Review your notes, do practice questions, and try to connect what you've learned today with other conditions and nursing concepts. The more you integrate this knowledge, the stronger your clinical judgment will become. I know you're all working incredibly hard, and I'm cheering you on every step of the way. Thanks for watching our NCLEX-RN review on liver cirrhosis. Don't forget to like this video if you found it helpful, subscribe to the channel for more nursing content, and definitely hit that bell icon so you don't miss out on future reviews and tips. Your engagement really helps support the channel and allows me to create more content like this for you. Good luck on your exams, and I'll see you in the next video.